Yeah, great. So my name's Danyal. I'm a neurosurgery resident in London and a research fellow in the surgical technology group in Queen's Square. I've been with the group for 5 years and I'm now doing a PhD. My interests are in the application of surgical technology in skull-based neurosurgery, and my doctoral thesis is applying AI to pituitary surgery. The type of AI I'm interested in is called computer vision. You might have come across this actually, whether you know it or not, through Google Photos or through your Apple Photos, where you see recognition of the face and pulling out other photos that look similar to that. Or if you search something like dog in your iPhone and see loads of images come up in your album. It's using similar technology, but we're applying it in a surgical sense. What I mean by that is we're feeding surgical videos into these AI models in an attempt to get it to learn what we're doing in that surgery, what structures we're seeing, and what might happen next. And I think there's probably two main ways that we're going to do this. The first way is almost using it like SatNav during an operation. So when we get to a part of an operation where there are critical structures around, so important arteries that supply the brain, important nerves that control your movements of your eyes and how you perceive the world, so your vision, the surgeon can lean on this AI or perhaps get a recommendation from this computer vision model of where these structures might be. The reason why it's important is because we already have loads of technology to help us identify and orientate ourselves to these structures. And it's really hard because basically the processes that happen, so usually we're operating, for example, on tumours in this region, can distort what we expect to see as normal. The other spoke, which I think is probably the most interesting, but also the hardest to do, is predicting outcomes. And what I mean by this is outcomes that we currently are really bad at predicting. So in pituitary surgery, the classic example of that is these patients often have hormonal issues or salt balance issues after the operation. With this underpinning computer vision technology that's analysing the video, we're looking at linking it with the data before, during, and some of the post-operative data to be able to predict these outcomes a bit more robustly. And I think that will have material benefits to patients. You know, can we detect complications or these outcomes a bit earlier, and can we act on that? Can we institute prophylactic treatments? Can we discharge patients home who are safe to go home, so are at low risk of all of those issues sooner, and spare them from a prolonged hospital stay, spare the healthcare system from that as well. And more importantly, for those who are at higher risk, know to monitor them more closely, perhaps prolong their stay to keep them safer. So they're the kind of two main spokes of this. And I've tried to tie it back to both the surgeon's needs to deliver effective care, but also what the patients we think would benefit from the most. And I phrase it like that because that's the way we've approached it for the last however many years in medical research, what we think is the best. We've been really careful to make sure what we think aligns with what our patients think. And in parallel to a lot of this surgical technology research, and I'm sure you'll hear about it on other videos on our channel, we've been doing a lot of work with patients to gather their perceptions on what's actually important for them. What is the safest and best way to apply technologies like computer vision, like robotics, like neurotechnology that you've heard about before, to get them the most material gains to address their primary concerns. So, as I say, in parallel to a lot of this surgical technology research, we've been doing a lot of work to gather that list and make sure that our work lines up with patient priorities. There's a few challenges. The first part is the kind of a challenge that occurs throughout the life cycle, if you say, of the device. So that is that these are complicated things to develop from conception, so thinking of the idea, making sure that it's aligned with an unmet need clinically and it's aligned with patient priorities, to a product actually being developed and translated in the hospital. Along that whole spectrum, there are hundreds of different people involved from various different specialties, different interests, coming from it from different perspectives and different views. So probably the biggest challenge is making sure everyone's singing from the same hymn sheet. So we're working together, we're very goal focused, and we're able to communicate with each other in a reasonable way. And I think once you achieve that level of team working, which takes a long time to build, and obviously is very resource intensive, then a lot of the other problems become a lot easier. I think some of the specific problems that are hard to address are like you said, Ollie, about the interaction with making sure that things are designed so that they help rather than distract. So if you take the SatNav kind of project that I called it, we've done a lot of what we call user studies, and we've actually taken that inspiration from industries. So I'm sure everybody's sick of getting questions about doing surveys or market research from various companies on their products. We've kind of taken inspiration from that and built that into a lot of our research pipeline, and watching how users interact with our devices as we develop them. What that's allowed us to do is to make sure that whatever way we're developing this technology, it's genuinely useful. And a common theme that we've been seeing, not only just within surgical AI, but probably medical AI more generally, is a real focus towards not comparing humans versus AI, but rather comparing a human alone versus a human augmented by technology. So if you take this SatNav example, the SatNav is on a separate screen. It's totally controlled by the surgeon. So when they feel ready to receive that information, or when they want that assistance, or that reference, it's available on command. There's a lot of debate about this, whether it should be there automatically, whether it should be smart, should it be giving you certain types of prompts. At least for our pipeline of research, and what we've realized so far is that we don't want to overburden surgeons in an otherwise quite stressful environment, and it should be on demand. So that's kind of one very high level example of why you need to ask people, and why when you're iterating these technologies, and they need to be aligned to the people who are going to actually use them. That's really important, and I think that's often overlooked.